Hey everyone, it's Sarah with registerednursern.com, and in this video I'm going to be going over part 2 of heart failure. This video is part of a cardiovascular NCLEX review series that I'm going to be covering, and in the previous video I covered part 1 of heart failure, and I talked about the patho of heart failure, the signs and symptoms, the different types and things like that. So if you haven't watched that video, be sure to check that out because that video builds upon this video, and a card should be popping up so you can access that. So what I'm going to do in this video is I'm going to be covering the nursing interventions and the medications given specifically in heart failure, because that is really what the NCLEX exam and your nursing lecture exams like to hit on, because as the nurse you need to know what your role is, you need to know how to educate the patient and those common side effects of those medications you'll be giving in heart failure. And then after you watch this lecture, be sure to go to my website, registerednursern.com, and take the free NCLEX quiz that will test you on heart failure. And a card should be popping up so you can access that. So let's get started. First, let's recap and talk about what is heart failure. Heart failure is where the heart is too weak to pump efficiently, so it can't properly give your body the cardiac output it needs to maintain the metabolic needs. So you get some major issues going on. And remember from the other video, your left side of your heart or your right side of the heart can be affected, or you can have both. So remember, with left-sided heart failure, you're going to get the pulmonary symptoms, and with right-sided heart failure, you're going to get those peripheral symptoms. And the most common type of heart failure is left-sided, and it can cause right-sided heart failure. So keep those things in mind whenever we're talking about medications and things like that. So what are the nursing interventions? Let's cover that first. What is your role? As a nurse, in a nutshell, what you're going to be doing is you're going to be assessing that patient, educating that patient, and administering medications. So first, let's talk about the assessing part. What are you going to be doing? Okay, as a nurse, you are going to be assessing their symptoms. How are their symptoms? Are they presenting worse than before? Like, if they're in right-sided heart failure, how is that peripheral swelling? Is it going down? Because chances are they're going to be on medications. Are they responding appropriately to that? Or are they getting worse? Left side, remember you get those pulmonary issues. Is the patient breathing better? Is there less crackles? How are they doing with that? Next, you're going to be assessing the patient's responsiveness to those medications. Medications such as Digoxin, you got to watch that heart rate because it can slow the heart rate down. Beta blockers, things like that. So you want to have them on continuous monitoring or be checking their vital signs often. Watching their blood pressure because they're going to be on ACE inhibitors, ARBs, or vasodilators, and that really messes with the blood pressure. And plus, you're shifting fluids out of the body. They're in fluid overload, and you're getting rid of fluids because they're at risk for orthostatic hypotension. And you're going to be monitoring their volume status because we're trying to diurese them. We're trying to remove that fluid. So they're going to be on diuretics. Chances are the physician will order a Foley catheter because a lot of times these patients come in, they're in fluid overload, they're going to be started on IV, maybe loop diuretics like Lasix. It's very strong diuretic, especially going the intravenous route. So they may need a Foley to help drain all that urine that's going to be coming out, because getting up and going to the bathroom will wear them out because their respiratory system is already compromised, and just going back and forth to the bathroom puts a lot of strain on them. And you're going to be monitoring, assessing those daily weights. Every morning you're going to get them up on a scale or use the bed scale. And you want to monitor that weight because it's very important how much weight they're losing or possibly gaining. Then you're going to monitor and look at those labs. Specifically, you really want to watch potassium levels because a lot of the medications given in heart failure can cause hypokalemia or hyperkalemia. For instance, Lasix. Lasix is a diuretic that wastes potassium. So you really got to monitor that Lasix level. Especially if they're on Digoxin, because if you have low potassium, that can increase the chances of Digoxin toxicity. Hyperkalemia. Medications that can cause that are sometimes prescribed in heart failure are like those potassium-sparing diuretics that actually do the opposite of loop diuretics. They keep potassium, like aldactone. And ACE inhibitors and ARBs, they can increase potassium. So if you have a patient on an ACE inhibitor and aldactone, they are at major risk for hyperkalemia. So you have to tell the patient to watch their potassium intake. Also, you're going to be assessing and making sure they are following their cardiac diet and their fluid restriction diet. A lot of patients have issues with this because especially the fluid restriction diet. Normally they can only have about 2 liters of fluid a day. So you have to constantly monitor what they're having for breakfast, for lunch and dinner and in between. Make sure they're not cheating on that diet because we're getting rid of that extra fluid and we don't want to just be putting it back in. Then we're going to assess the edema in the legs. That goes back to the patient's responsiveness. Helping keep those legs elevated whenever they're in bed will help promote returning that extra fluid back into the vascular system, hopefully being excreted through the kidneys, and keeping them in high Fowler's position to help with respiratory. That position, sitting upright, helps the lungs expand and helps decrease dyspnea. Next, safety. This is a big issue with your heart failure patients because, number one, chances are they're going to be on some vasodilators or some other blood pressure medicine, and the body, whenever they shift positions, maybe lying in the bed, they get up, they can get really dizzy and they're at risk for falling. So you want to make sure you monitor them for that. And the extra swelling in the legs and the feet make it really hard to walk and put the feet on the ground, and it can lead to them falling. Okay, now educating. This is a big piece, so remember this stuff, write it down, because as the nurse, we want to educate our patients with heart failure. And regardless if you're not working on a cardiac unit, maybe you're going to work on ortho, your chances are you're going to get patients with heart failure because this affects a lot of patients. So our goal with educating is that we want to prevent readmission. This disease process causes a lot of readmissions to the hospital. And we want to prevent heart failure exacerbation. So what you want to teach your patients is the following. Follow a low sodium diet. Guidelines are no more than 2 grams per day, sometimes 3. So no more than 2 to 3 grams of sodium per day in your diet. Watch the hidden salts like in canned foods, your sandwich meat, your frozen meals, things like that you wouldn't normally think have a lot of sodium in but do in soft drinks. Next, fluid restriction. The doctor wants them on fluid restriction. They need to make sure they monitor how much they drink a day because some of these medications can make you thirsty. So no more than 2 liters a day of fluid. Vaccinations, make sure that they need to be aware that they need to get an annual flu vaccine and that they're up to date on their pneumonia vaccine because illnesses can exacerbate heart failure because it stresses the heart out when a patient gets sick. Next, aerobic exercises. That's like your cardiovascular exercise. They need to do light to moderate exercise to keep that muscle nice and strong and do that as tolerated once their symptoms start dissipating. Next, daily weights. It is so important that they weigh themselves every day because it is an early sign of CHF, heart failure exacerbation, if they're gaining weight. So the guideline is if they're weighing themselves, make sure they're writing them down. They need to notify their doctor if they're gaining any more than 2 to 3 pounds per day or 5 pounds per week. That is signaling, hey, you're starting to retain fluid, something's going on, let's go to the doctor. Maybe they can prescribe some more diuretics so I don't have to go to the hospital and readmit it. So daily weight's very important. Next, compliance with medications. A lot of times, especially working as a nurse, I have just seen where patients have quit taking their medicines. Maybe they couldn't afford their medicines, so they quit taking them. And this sent them into heart failure exacerbation. So very important they take those medicines. Next, smoking cessation. Quit smoking, very bad with the heart, causes vasoconstriction, hard on the heart. And limiting alcohol consumption. Next, teach your patient those early signs and symptoms. We just talked about the weight gain. Also, if they notice that all of a sudden they can't tolerate normal activities that they were doing, like just getting up and going into the kitchen, they notice that they're starting to get a little short of breath. Or at night, whenever they're trying to sleep, that they have to put a couple pillows behind them to sleep better, which is called orthopenia. Those are some warning signs that, hey, I may be going into heart failure exacerbation. Now let's look at the medications for heart failure. When you're studying these medications for the NCLEX or for your nursing lecture exams, make sure you know the drug categories that are given in heart failure and what drugs are included in that category and how they work on the body, the pharmacodynamics and their side effects, and patient education. Very important key points you want to remember. Okay, to help you remember the drug categories that are given in heart failure, remember this mnemonic. Always administer drugs before a ventricle dies. In heart failure, our issue is with the ventricles. They are either not pumping, they're not contracting properly, or they're too stiff, so they're not filling properly. So we want to make this heart work easier, especially these ventricles. So that mnemonic should help you remember those drugs that are included. So the first A, ACE inhibitors. ACE inhibitor stands for angiotensin converting enzyme. And this is usually the first line of treatment in patients with heart failure. And it's sometimes prescribed with a beta blocker, which we'll go over a little bit later. These drugs tend to end in PRIL, and one example of an ACE inhibitor is lisinopril. And how this drug works is that it blocks the conversion of angiotensin 1 to angiotensin 2. So you don't have the conversion of angiotensin 1 going to angiotensin 2. And how does that work? Well, we know whenever angiotensin 2 works, it causes vasoconstriction, but it's not allowed to do that. So in turn, you're going to get vasodilation, which is going to decrease the blood pressure. And you're going to get kidney excretion of sodium. Think back. Whenever angiotensin is being blocked, what's going to happen is it's going to cause your aldosterone levels to decrease. What does aldosterone do? Aldosterone, whenever it's being decreased, it will cause your kidneys to keep potassium but excrete sodium, which is what we want in heart failure. We're trying to get rid of all that extra sodium and fluid in the body, and this drug is helping us get rid of that extra sodium. However, because it's doing that, it's going to keep this potassium but get rid of the sodium. We have to watch out for side effects of hyperkalemia, high potassium levels. And for some reason with this drug, these patients can develop a nagging dry cough. And I have seen this as a nurse. It's for real, and it really does happen. They will literally cough every 3 to 4 minutes, just this, just over and over and over. And it drives them crazy, and it drives the people around them crazy. So some people can't tolerate this drug. Next drug, ARBs. If the patient cannot tolerate an ACE inhibitor, they'll be placed on an ARB. And how do ARBs work? ARB stands for angiotensin 2 receptor blockers. So they're a little bit similar. So let's look. Okay, these, like I said, are used in place of ACE inhibitors. They end in sartan, S-A-R-T-A-N. Type of drug of this is losartan. And they work by blocking angiotensin 2 receptors. So instead of blocking the conversion of angiotensin 1 to angiotensin 2 like the ACE inhibitors did, this works by just blocking the receptors. So again, you're going to get some vasodilation, and it's going to have the same effects on the body as your ACE inhibitors. It's because you're going to have that decreased aldosterone, and the patient's going to keep potassium but excrete sodium. However, a side effect with this is hyperkalemia, just like with ACE inhibitors, but they will not get that dry, hacking cough. Okay, our other drug, diuretics, D. These, either patient will be prescribed on loop diuretics or potassium-sparing diuretics. And these diuretics are used in a combination with these ACE inhibitors or an ARB. They're used together. And what your diuretics do is it helps your body get rid of that water and that sodium retention, because in heart failure, what we're doing is we're retaining all this water. We got edema everywhere, and we're retaining sodium. So it helps us to excrete that, decrease that edema, and it helps the heart pump easier because it doesn't have all that fluid volume in its chambers trying to pump. So it's getting rid of that. However, a side effect of this is that this patient will urinate a lot. So as a nurse, you want to be monitoring that urine output very, very closely. And you want to monitor their BUN and creatinine, making sure we're not diuresing them too much and putting too much strain on those kidneys. Okay, an example of a loop diuretic is Lasix. Remember, with Lasix or loop diuretics, they waste potassium. So before you give before you give Lasix, check those potassium levels to make sure that they're good, because you go in and give some Lasix and their potassium level's already 2, you're going to bottom that out even more. So a lot of times physicians will prescribe potassium supplements along with Lasix. And potassium sparing drugs, a drug Aldactone. What these do, they do the opposite of loop diuretics. They keep potassium. So you have to watch out for, educate the patient not to consume foods that are high in potassium, and to especially watch if your patient is on an ACE or an ARB, because remember, they keep potassium, and if they're taking Aldactone, you have a double risk of increasing that potassium level. Next, beta blockers. How do beta blockers work? They work by blocking the norepinephrine effects on the heart muscles. So norepinephrine will naturally increase your heart rate, so we're going to block that from happening. So beta blockers are going to slow down the heart rate. They have a negative inotropic effect, which decreases myocardial contraction, hence a fancy word for slowing the heart rate, which will in turn decrease your heart's workload because it is overworked in heart failure. These drugs end in LOL. Typical ones used in heart failure are metoprolol, carvedilol, and bisoprolol. Now, typically, the way that these beta blockers work, they slow down your heart, so they weaken the heart's contraction. So in some forms of heart failure, especially acute heart failure that deals with systolic dysfunction, you don't initially want to use these beta blockers, because let's think back to the other lecture. What is systolic ventricular dysfunction? Systolic, that is the squeezing phase of the heart. So there is an issue with this ventricle being able to squeeze that blood out. So if this patient is an acute systolic dysfunction and we throw a beta blocker on them, it's going to weaken that heart contraction even more, and we don't want to do that because we have a contraction problem. So sometimes the beta blockers will be used in stable systolic dysfunction, and a lot of times these beta blockers are prescribed with ACE inhibitors or those ARBs in combination. Now, a lot of times beta blockers are used in diastolic dysfunction heart failure. And what was ventricular diastolic dysfunction? That was where, remember, diastole is the filling phase of the heart, the resting phase, and there's an issue with the ventricle. Maybe it's too stiff and it doesn't fill properly with all that blood it needs to fill with. But what a beta blocker can do is slow down that heart rate, let that ventricle rest a little bit longer and fill more with blood so it can squeeze it out, because its squeezing mechanism's great, it's just the filling. So sometimes it will be used to treat ventricular diastolic dysfunction. Now, side effects of your beta blockers, remember this. Bradycardia, so before you give a beta blocker, check the heart rate, make sure they're not too bradycardic. It can mask hypoglycemic signs and symptoms in diabetics. A lot of times a diabetic knows when their sugar's low because they may get tachycardic. Hence, you're not going to get tachycardic with bradycardia with beta blockers because it slows the heart rate down, or they can get sweaty, things like that, and that masks those symptoms. So you need to teach your diabetics that. And beta blockers can cause respiratory issues. So they're typically not prescribed, especially the ones that aren't selective, for patients with COPD or asthma, because it could cause bronchoconstriction. And whenever the patients take these, tell them not to take them with any type of juices, especially grapefruit juice, because it can interfere with your body's absorption of the beta blockers. Okay, next, let's look at A for anticoagulants. These are not used in every patient with heart failure. So typically it's going to be used in heart failure patients who, a lot of times, heart failure and atrial fibrillation go hand in hand. And you know, with AFib, those are just quivering, blood is pooling in there. When blood pools, that's not good because a clot can form, can shoot through the heart, and we can have an embolism. So if a patient's in AFib with heart failure, they may be started on an anticoagulant, or they have a history of blood clots, or they have an ejection fraction less than 35%. We talked about in the other video what ejection fraction was, and this is where your heart is not squeezing all that blood out properly, so contraction isn't good. And if it's not squeezing all that blood out that's normally going in there with systolic dysfunction, you're going to have more blood pool in there, so there's an increased chance of developing a clot and shooting it through the heart. Okay, next, V for vasodilators. A lot of times these are prescribed if a patient can't tolerate an ACE inhibitor or an ARB, because it works by causing dilation. And one drug, which is an arterial dilator, is hydralazine, and it's a lot of times sometimes prescribed with a nitrate called Isordil, and that is a venous dilator. Hydralazine is a specific drug that acts specifically on your arteries, and Isordil is what acts on your veins. So what happens is that you get dilation going on of those arteries and veins. How does this work? How does it benefit the heart? It decreases blood and fluid going back to the heart, because the heart is already overloaded in heart failure with all this blood and all this fluid. So we got all this nice dilation going on, and it will decrease the amount of fluid that's going back and the workload that your heart has to undergo. However, side effects with this are hypotension, because anytime you have dilation going on, the patient is at risk for hypertension. So you want to measure that blood pressure, make sure it's good before you give it, and they are at risk for orthostatic hypotension. So say your patient's on these medications, they're laying in bed, they need to get up to go to the bathroom. You want to get them up slowly and gradually, because they can get dizzy, they can pass out and fall, so you want to watch safety issues with that. Next, D for digoxin. How does digoxin work on the body? I would remember this for sure. Okay, it has a positive inotropic mechanism, which means that the heart has an increased ability to pump stronger. However, it has a negative chronotropic mechanism that allows it to beat slower. So it's a win-win. It beats slower, but it pumps more efficiently, so this allows the heart to rest and pump more blood, which is great if you have left ventricular systolic dysfunction, which is what this drug is sometimes used in. However, it's not used as first-line treatment for heart failure. It's going to be used alongside with your ACE inhibitors or your diuretics, because digoxin can be a nasty drug. It has toxicity issues. And if a patient has a low potassium level, goes into hypokalemia, potassium level less than 3.5, they can go into digoxin toxicity. So with this drug, you want to monitor the drug levels. I would remember this. A normal digoxin level is 0.5 to 2 nanograms per milliliter. This is where you want that patient to hang out. Anything higher than 2 is bad, digoxin toxicity. And signs and symptoms of dig toxicity, classic, I have seen this. This does happen. They'll have nausea and vomiting, and they'll report some vision changes. They may all of a sudden start seeing some yellowish green halos. They can be bradycardic as well. And what would happen, you notify the physician immediately, don't give another dose of digoxin, and the physician will probably order the antidote for digoxin, which is Digibine. Very easy to remember. It tells you what it is. Digibine, D-I-G-I-B-I-N-D, matches digoxin. That is the antidote for that. Whenever you are giving digoxin as a nurse, you always want to check the apical pulse and make sure it's greater than 60 beats per minute before giving the dose. Okay, so that is a review, the part 2 review of heart failure. Be sure to go to my website, registerednursern.com, and take that free quiz. And thank you so much for watching. And please consider subscribing to this YouTube channel.